Okay, so I'm Jessica Canales. I'm going to be talking to you guys about emergency neonatal care for veterinary technicians. We're going to start with an overview, and then we're going to get into normal husbandry and care, including things like development, thermoregulation, feeding, and elimination. And then we're going to move on to fluid therapy and administration, and then regular monitoring when hospitalized. So to start, just an overview on why we want to focus on neonatal care. So our neonatal patients can be some of the most critical and difficult to care for due to their unique physiology. It's really important for us as veterinary technicians to feel comfortable caring for these patients since they are so vulnerable and time is very critical with these guys. Like I said, in this presentation, we're going to cover normal husbandry and development, fluid therapy and administration, and then regular monitoring for these patients while they're in the hospital. We're going to start with normal husbandry and care. So first we need to know what is normal about our neonatal patients. In order to properly assess your neonatal patients, we need to know what's going to be normal at each stage of development. So we should start with our full physical exam to see what is going on, what stage of development we're at, and where there might be any deficits. And we should examine them for any potential genetic abnormalities that could contribute to their health as well. So starting with our development and reflexes, some of our main ones that we want to look at with our neonatal patients would be starting with opening up their eyes. That's going to start around 10 to 14 days of age. So prior to that, it's going to be normal if their eyes are closed, and this can be a good indicator of how old they are. Their vision is going to be blurry up until around 4 weeks of age. They will have a palpebral reflex prior to opening their eyes, but they will not develop a menace response until around 3 weeks of age. So that's something that you don't have to be alarmed about if they don't have that right away. The PLRs are also not going to be able to be appreciated until around 3 weeks of age, and that's due to development of the muscles involved there. They will be born with a withdrawal reflex, so that is something that you can check right away. And neonates under 3 weeks will urinate and defecate with stimulation. So that's something that they should be able to do during that time as well. They should have a strong suckling reflex, that's really important, and the ability to right themselves into sternal if they're placed in lateral recumbency. Lack of any of these reflexes should be noted and identified on examination because they can cause problems in the future and with their nutrition when they're not suckling and things like that as well. So moving on to thermoregulation. Our neonatal patients lack the ability to thermoregulate until they're about 4 weeks of age. So it's really important that we warm them correctly. Hypothermia has huge impacts on their nursing, immunity, and overall health in general. So when you do have patients that are hypothermic, it's really important to actually slowly rewarm them over about 30 minutes because rewarming them too quickly could cause vasodilation, which would cause more dehydration, which we know can be fatal in our neonatal patients. It's important to hold on any feedings, including tube feedings, until the patient is warmed appropriately, because it can cause regurgitation and aspiration and the inability to really digest appropriately. We should also avoid using alcohol on these patients as much as possible, since that can cause them to cool down too much as well. So just some additional things to think about with our neonates. We also want to be aware of potential overheating. If we are using a heat source, if we're going to be keeping them on a heating pad or a fluid line warmer, we want to make sure that we are monitoring their temperature regularly because there is that potential for overheating, which we know can also cause problems. So moving on to nutrition, this is a big one with our neonates. It's important that they are fed frequently, generally every 2 to 4 hours, depending on their age, more often the younger that they are. And it's important that they're fed appropriately. There's a lot of different ways to do feeding, so we're going to go through a couple of those different options. Either way, if they are, so we'll start with if they're nursing. If they are nursing with their mother, allow for natural feeding. We do still want to monitor their weights If they're not gaining appropriately, we might need to do some supplementation with them. And then we always need to be checking for adequate milk production. Neonates have that suckling reflex, so they may be suckling without getting any actual milk out. So it's really important that we're also regularly checking for milk production. If they are unable to nurse, or they're not getting enough, or they're orphan, whatever the reason may be, we need to do their feeding for them. So we're going to talk a little bit more about how to do that. We should be using species specific formula, of course. There's puppy and kitten formulas, and they should be prepared appropriately. We also want to always make sure to keep them in sternal when we're doing any kind of feeding to prevent aspiration, and also check for swallowing. I use a weigh, feed, weigh technique when doing their feeding, which is having a 5% increase in body weight for each feeding that they're gaining. So this is what that looks like with our chart here. So what you're doing is you're going to weigh them before you feed them in grams, and then you're going to weigh them after they're done feeding. So if you're bottle feeding or syringe feeding, whatever that may be, weigh them afterwards to make sure that they have gained an appropriate amount. So if their weight was 100 grams, they should weigh at least 105 afterwards, meaning that they had that 5% increase. This is just a more exact way of making sure that they've actually gotten the food that they need, as opposed to just making sure that they got, 5 mils of formula. This is ensuring that they got this into their body. So this should be done for any kind of feeding. So we'll start with bottle feeding. Our bottle feeding, again, needs to be done every 2 to 4 hours, depending on their age. The amount is going to depend on their size. That's going to be that 5% of their body weight using our weigh, feed, weigh method. When feeding, you want to allow them to be positioned upright or sternal. They should never be on their back or on their side because that can cause aspiration. So start by allowing the patient to explore the nipple and begin suckling on their own. Once the patient has stopped showing interest in the bottle, go ahead and weigh them. So let them suckle and drink as much as they want, then weigh them to check that they've eaten the full amount. So as long as they've had that full amount where they've gained based on that scale, then they're okay. If they've had more, that's totally fine. This is just our minimum requirement. But if they have not had enough, then we might need to do some additional feeding, whether that be with a syringe or with tube feeding. So moving on to syringe feeding, this might be necessary for our patients that won't accept the bottle, or if they just need additional after they've had some of the bottle. So again, we're going to be doing the weigh, feed, weigh method with this. It'll be the same amounts. You're just going to be using a syringe this time. The key to syringe feeding is making sure that you're going slow, and again, you're keeping the patient upright. You should also be making sure that they are consistently swallowing anytime you are putting drops in their mouth. So I like to make sure to have a finger under their neck so that you can actually feel them swallowing as you're feeding them. If they are not swallowing or they're fighting it and they really don't want to be doing this, take a break, give them a moment. We may need to go on to tube feeding at this point, but you can give them a little bit of a break and then try again. You don't want to do this too quickly because it can, again, cause aspiration pneumonia, which we know can be fatal for them. So we want to make sure that we are doing this appropriately. One thing that I also like to do when doing syringe feeding is, if you're able to get, there's some special types of nipples that you can actually put on the end of the syringes. This can help a lot for our patients that aren't quite suckling well enough to help transition them to a bottle eventually by putting the nipple on the end of the syringe, and it just makes it a little bit more comfortable for them than the plastic syringe would be. So that's something to keep in mind as well if you do a lot of this. So moving on to tube feeding, we can utilize our tube feeding, again, every 2 to 4 hours as needed. This is going to be really good for our patients who are unable to suckle. If done correctly, tube feeding can help provide our adequate nutrition without risking the aspiration pneumonia with forced syringe feeding. That's one of the problems that you can come across with syringe feeding or even with bottle feeding, is if they are not swallowing appropriately, having that aspiration pneumonia. So it is, of course, really important, though, that tube feeding is done correctly, because it could cause more problems if we're not placing it correctly. And it can also cause overfeeding if we're not administering it correctly. So we want to make sure that the amounts we're giving are correct and our placement is correct. So there's two main types of tube feeding that we like to do in our neonates. First one is going to be orogastric. So this can be used for our shorter term tube feedings. So the tube's not actually staying in the patient. We place it each time we're feeding the patient. These are ones, this is what I use a lot for patients who are not necessarily suckling quite yet, where you can start by offering the bottle first, see if they'll use it. If not, then you can go to your tube. You should always try to offer the bottle first to see if they will use it, but this helps for when they're not suckling appropriately. So you'll use a 5 French red rubber tube. Make sure to measure your tube from the tip of the nose to the last rib and mark that spot with a piece of tape like on here. Put some lube on your tube and then feed it down the esophagus. It should feed really smoothly. You shouldn't really face any resistance. If there is any resistance or if the patient starts to cough, you should pull it out and start over because usually that means that there's something wrong with your placement. So feed the tube to that point that you have marked. Attach your syringe, pull back on your syringe, and you should ideally get negative pressure. If you get air, then you're most likely in the wrong spot and need to pull back out. So you should get negative pressure when you do that. And then once you have ensured that you are in the right spot, you can start administering the formula slowly. And then once completed, before you remove it, make sure you pinch off the tube and then pull it out in one movement. So that is for our orogastric tube placement. We can also do nasogastric tube placement. This is going to be if we want it to be longer term for our patients, similar to what we would do in our adult patients as well. You can use a 3.5 French red rubber tube or a pediatric feeding tube, depending on what you have in your hospital. Measure your tube again from the tip of the nose to the last rib and mark that spot. Place a drop of lidocaine in the nostril and then feed the tube down the nostril to the mark. It should feed pretty smoothly. You shouldn't face too much resistance if you're in the right spot. And then you'll suture that into place, and you can take a placement radiograph for this to confirm your placement. And then again, with administering the appropriate amount of formula slowly and making sure it's warm as you would if you were giving it through the syringe or bottle feeding as well. So when we talk about nutrition, I also like to talk about hypoglycemia. Hypoglycemia is a major concern with our neonatal patients. Our neonates have minimal fat reserves, so even a short period of time without adequate nutrition can lead to really severe hypoglycemia. It can be reversed with using IV or oral dextrose, but hypoglycemia is something that we should always consider and think about with our neonatal patients. When we're taking a history, we should always ask when they last ate, how much they ate during that time, and we should always check our glucose levels when they present for emergency. And then elimination. So if your patients are under 4 weeks of age, you will need to stimulate them to eliminate after each feeding. You're going to do this by using a warm washcloth, or you can use a baby wipe, something like that, and rubbing it on their genitals until they urinate and defecate. It's really important to monitor the stool and urine produced by our neonatal patients because that can be really telling of their health. Diarrhea is one of the leading causes of dehydration in these patients and can be very fatal very quickly. So keeping an eye on that in particular, what it looks like, the consistency, how often it's happening, that's really, really important. Diarrhea itself can be indicative of a lot of different things. It could be inappropriate nutrition, parasites. inadequate immunity, sepsis, and other various diseases. So making note and tracking diarrhea is very, very important. We also can see constipation in these patients, especially ones that are being fed with formula. That change in their diet or various things like that could cause constipation as well. So on both sides of the spectrum, we need to make sure that we are keeping an eye on their stool production. Urine color and concentration is also very helpful as an indicator for their hydration. So we should be monitoring the volume and the color of their urine. They should urinate every time you stimulate them to go. So make sure to keep doing that until they have urinated. And as far as defecation goes, we want to see that at least once a day. Ideally, it would be at least once a day. Too often, again, can be something that could lead to dehydration, and then not often enough, we might be constipated and cause some more issues. So make sure you're monitoring that on top of the consistency. Okay, so now we're going to move on to fluid therapy and administration. Fluid therapy and IV or IO access should be started immediately on these patients. An IO catheter may be indicated if the patient is too small for an IV catheter. Things to remember when placing a catheter, though, is that you can use the jugular vein. So I know our smaller neonates, they can be really tricky with our IV catheters. Generally, we might go for the cephalic, but for tiny neonates, days old, that's going to be very, very small. So we can consider the jugular vein. We should consider that, but we also can consider placing an IO catheter if needed. We can use a 22 or 25 gauge needle for our neonatal patients as an IO catheter, and we can use this to administer fluids, diluted dextrose, antibiotics, and blood products. Anytime you are performing any kind of venipuncture on a neonatal patient, if we're trying to place an IV catheter, be aware of the size you're using and blood loss. If you need to be collecting blood for anything, collect a small amount, the smallest amount you're able to. And if you are needing to stick them for things, try to avoid multiple sticks because even a small amount of blood loss in these patients can be detrimental to them. So keep your eye on that and think about that when you are placing IV catheters so that you're not causing them to bleed too much. So then what about sub-Q fluids? So subcutaneous fluids can be used for our non-critical patients, but they really should not be relied on for our critical neonates. The absorption time is a lot slower, and with these patients, time is everything, and dehydration can be very severe and can become fatal very, very quickly. So don't rely on your subcutaneous fluids for your emergency patients. We should try to get IV or IO access in them as soon as possible. So placing our IO catheter, there's a couple different locations where we can place these in our patients. The greater trochanter, the wing of the ilium, and the proximal humerus are usually the easiest for these patients. The greater trochanter is what I use the most, just placement wise. It tends to work best with our neonates. So I'm going to go over the steps for that. So you start by clipping and prepping the skin over the greater trochanter. So you should get that clipped really well and then prep it with some scrub. If the patient is remaining conscious for this, administer local anesthetic to the insertion site. So you can use lidocaine, administer that subcutaneously over the point of insertion and then extending down the limb. Hold the stifle in one hand with your thumb laying along the long axis of the femur and the ball of the thumb over the greater trochanter. Direct your needle into the bone, keeping the needle parallel to your thumb at all times. Advance the needle with a rotary motion, so you're going to be kind of rotating it a little bit as you're placing it in. When the needle passes through the bone into the marrow cavity, the feeling of resistance should decrease, so you'll feel it kind of pop in there. Once in place, you want to check for proper placement by manipulating the femur, make sure it's in there, and you should be able to easily flush it. If it's going to be staying long-term, you can suture it in place, but if you're just going to be using it for your rescue drugs or a dextrose bolus, fluid bolus, that kind of thing, you can bandage it carefully and leave it in place while you need it. For fluids, so like I mentioned before, dehydration in our neonates can become fatal very quickly, so we want to get fluids going, and we need to consider all of our factors that could be causing additional dehydration. So our maintenance rate for neonates is 90 mils per kg per day, but we also want to factor in our percentage of dehydration and consider factors like diarrhea, as well when you are determining that level of dehydration, because that can speed up that dehydration quite a bit. And then our dextrose CRIs, this may be indicated for our hypoglycemic patients. If possible, you should try to use a burette or use a syringe on a syringe pump, since you might be changing this dextrose concentration regularly for these patients. We want to make sure that if we are having them on a dextrose CRI, or if we're just doing a bolus to start with, we are regularly monitoring their glucose so that we are doing them. Ideally, we should reassess their glucose every 2 hours and make adjustments as needed on their CRI. Your vet may want to do it more often when you're getting started to find out what kind of that sweet spot for that patient is going to be. Okay, and now, so we've covered how we're going to take care of them, first assessing them, getting fluids started, and now when we're hospitalizing them, there are some things that we need to consider, especially with our neonatal patients when it comes to monitoring them. They can go downhill very quickly, so a lot of the things that we want to monitor with them, we need to do it very often. So vitals, monitoring vitals regularly is really important. Temperature is going to be one of the most important ones. Since they can't regulate their body temperature, we need to make sure that we are monitoring them regularly, especially if they are on a heat source, because we don't want to overheat them. We want to make sure that we are heating them appropriately. Our normal values, so puppies and kittens for the first week, 96 to 98 is normal, and then it gradually increases to 100 by 4 weeks. And then kittens are similar, it's 98 for the first week, and then it'll rise to 100 by the second week. So keep in mind these values for our neonatal patients are a little bit different than our adults. And we want to make sure, like I said, that we are monitoring these regularly if we are using a heat source. Or if we're not using a heat source, if we are using one and then we turn it off, we still want to be monitoring them in case we need to turn it back on. Moving on to our heart rate and our respiratory rates. So for our heart rate, over 200 is pretty normal for our neonatal patients. They tend to be higher than our adult patients. Bradycardia is the main concern that we're looking at with our heart rate. So if that is something that we're noting, we should definitely alert our DVM right away. And then respiratory rate should also be monitored closely. Normal is 15 to 35. And in any increase in effort, that's going to be our main thing, is our effort or any kind of crackling or wheezing is something that we need to report right away and take some action on, because that could be indicative of aspiration pneumonia, which is one of our biggest concerns with our neonatal patients. Moving on to our weight monitoring, we talked a little bit about this with feeding and how it's really important to be weighing them regularly. So we are going to be doing that weigh, feed, weigh, but we also want to make sure that we are weighing them consistently at least 3 to 4 times a day and putting that in their records in grams. That way we can monitor if they might be losing a little bit in between their feedings, if they did have a large amount of stool produced from their last one or something along those lines. But as far as consistency goes, we need to consistently be seeing gains. So notify your DVM if there are any signs of weight loss, especially if you are feeding them appropriately and they are still losing weight. We are definitely going to be concerned there. They should gain 5 to 10% of their body weight daily. So that should be their overall gain over the course of 24 hours. That's what they should maintain for a gain. But really any loss, if you notice any trend of weight loss, that is something that we need to address right away. Our glucose checks, again, we touched on this a little bit previously. You most likely are going to want to do serial glucose checks, especially if they come in hypoglycemic, and we have them on a dextrose CRI, because these levels can change regularly and we might need to change our concentrations. So make sure that you're doing these regularly and consistently. So if you're using a certain limb or something like that for your checks, make sure you keep that consistent. Our defecation and urination. So whether they are at an age where you have to stimulate them or not, you need to be monitoring this regularly. It's very telling to their health. And like we talked about before, diarrhea can cause severe dehydration, which can cause a lot of problems for them. So make sure that you are monitoring their defecation, and also for constipation too. Make sure if you are charting these things, you're looking to see when did they last defecate, how long has it been, is this normal, and the amount of it as well, because if they're just producing a small amount, that can be concerning as well, but also if they're producing a very large amount regularly, that is also concerning. So make sure that those details are in there, as well as what it looks like, color, consistency, that's all very important too. Because that can be indicative of nutrition absorption or issues with any other kinds of diseases. And then also make sure you're noting the urine color and volume, because this can change as well, especially with levels of hydration. So we want to make sure that they are urinating appropriately as well. And then we want to continue to monitor their development. We talked before about some of the developmental milestones for our neonates, and this is something, especially if they're going to be hospitalizing for a period of time, we need to make sure that we are checking at least daily to see where we are with our developmental milestones and making sure that they are hitting the milestones that we need them to, and that they aren't, backsliding or plateauing or anything like that. And then any delays or absences should definitely be noted and addressed, because that could be indicative of a more serious problem. So in conclusion, our proper monitoring and initial evaluation of our neonatal patients is key to providing proper care. As veterinary technicians, it's really important that we are comfortable with our neonatal patients and that we are familiar with their normal development so that we can identify the problems quickly. It's also really important that we are comfortable with things like feeding and that regular care for them so that we can provide them with the best care possible while they're in the hospital. So then these are my references, and then at this time I will hand it back over to Mariah and take the rest of the time to answer any questions anyone has.
If anybody wants to write any questions, we can ask those questions to Jessica. All right, there is one question. Do you have recommendations for diluting formula? Some will say that will prevent constipation.
Yeah, that's a really good question. So starting off, I do the regular dilution of formula, which is going to be 2 parts of warm water to 1 part of formula. And then if they are developing constipation from that, I will dilute it a little bit more. You could also start off with diluting it some more, so doing 4 parts of warm water to 1 part of formula, and then gradually going up to that 2 parts to 1 if you are concerned about constipation. But I usually start off with the regular 2 to 1 mix, and then we can make it more diluted if necessary if they are having issues with constipation.
Right. And then another question is, how often do you typically take a BG?
So when they first present, you should. And then if you're going to be doing a like a dextrose bolus or something like that, then you should take it following your bolus. If we're going to be having them on a dextrose CRI, usually every 2 hours or so, that we can adjust as needed. And then if you're not doing any kind of a CRI or anything like that, I would still recommend doing a BG every 2 to 4 hours when you're doing your feedings to make sure that you're in a good spot and that you don't need to add a CRI.
All right. And then there's another question. As RVTs, how can you receive training to place IO catheters? And if there's any sources or resources that you know of.
Yeah. I would recommend talking to your vets about that and seeing if they can help you with learning how to place them. They're usually going to be a really good source for you. There are some sources I've used. I believe it's the Clinician's Brief has a good article about how to place them and diagrams and everything about how to, but I would recommend talking to your DVMs and seeing if any of them would be able to help show you how to do it. It's a really good skill to have, even for adult animals like cats. You know, when you're having a really hard time finding a vein, it can be really, really helpful. It's a really good skill to have.
All right, thank you, Jessica. Right now there's no more questions. Just to let everybody know, you will be receiving your CE certificate probably within the week. And then this will be, was being recorded, so this will be placed up if you need to re-listen to this or want any more questions. You can always email Jessica. Do you have your email address on the presentation?
I do not, but it is, let me show you my, it's J and then my last name RVT@gmail. So here's, so it's JKANALOSRVT@gmail.com. And there's my last name up there.
All right, thanks everybody. Have a good evening.
Thank you.